have, and that's Lisa. Together, we're PD Connect. We're very excited to have Maria here with us today. I'm going to read the intro for you, and we'll go from there.
And her topic today
is
freezing of gait.
Yes,
what it is and what to do about it.
Right. All right. Maria has over 35 years of experience as a physical therapist, treating people with neurological disorders, primarily Parkinson's disease, severe brain injury, stroke, and vestibular dysfunction. She began to focus on working with the Parkinson's population in 2011. She became LSVT Big certified, then graduated on to Power Moves therapist and instructor certification courses in 2013 and 2014. She developed and currently serves as coordinator of a multidisciplinary Parkinson's wellness program for a home health company serving the Central Coast area of California, which now serves close to 300 people with Parkinson's disease each year. That's amazing.
That's a lot.
Yeah, that's a lot. She recently earned her certificate of advanced competency in home health. She is faculty for NeuroFit Networks, teaching Power Moves therapist certification courses throughout the U.S., which is actually where I first met Maria. I'm not a therapist, but the personal trainer one. And she was recently elected to the advisory board of the California chapter of Parkinson's Foundation.
That's a big deal.
That's a huge deal.
Yes. Maria Allen, we are so thankful that you are here, and we are going to spotlight you.
Okay.
All right. Sweet.
All right. Good. So I'm just going to say hello, and I'm happy to be here. And I know I'm following on the footsteps of some great speakers that Lisa and Steph have had on the last couple months. So today we're going to talk from a therapist perspective about freezing and freezing of gait. And I have a slideshow that I'm going to share my screen. And you are welcome to ask questions at any point in time. Raise your hand, Lisa and Steph can help figure that out. And I'll start here. And I'm going to minimize this and move that there. I think I have it all set. All right, so hopefully everyone can hear me and see the screen. So we're going to talk about freezing of gait in particular, and what it is, why it happens, and what you can do about it. Let's see if I have to go click down here. I don't have my. So mainly I'm going to talk a lot about what therapy can do to help, but we'll talk also about exercise and fitness. You have with PD Connect, you've got Lisa, who's an experienced therapist, and Steph, who's an experienced trainer, who both are Parkinson's specialists. So you've got a lot of resources right there for you to help you. So the definition of freezing is a little bit vague, but it's the temporary, involuntary inability to move. Now, it isn't just freezing of gait. You can have freezing of your thinking, your thoughts, your speech, your upper limb movements, your arm movements. So that freezing can happen in lots of different situations. And I am specifically going to talk more about freezing of gait. So in a perfect world, you'd have access to see a speech therapist, to see an occupational therapist, to kind of have that team. And that's one of the things I like about my current job is I get to work with the nurses, the physical therapist, the occupational therapist, the speech therapist, the social workers, the dietitian. I can kind of put together and work with the whole team because obviously Parkinson's is a complex disease with lots and lots of problems and lots of individuality. Each of you have your own set of symptoms and problems and all kinds of things to deal with. So freezing of gait, we're going to talk about gait today. And so what is it? It's a common and disabling symptom in Parkinson's disease. The statistics are kind of hard to come by, but some websites will say 50 to 80% of people with Parkinson's experience freezing. Some say 14 to 55%. Experience freezing. It does tend to be more of a problem in men, more of a problem in more severe PD. There are basically, they characterize two different types or phenotypes of Parkinson's disease. So there's the tremor dominant Parkinson's disease, which tremor is the primary and early symptom and primary symptom. And then there's the postural instability, gait dominant kind, and that kind of Parkinson's disease, or that phenotype, seems to have more freezing of gait associated with it. You also, the symptoms that are more associated with freezing of gait include cognition, decreases in cognition, especially executive function, more depression, more anxiety, and more motor problems. So could be a very disabling symptom for people in Parkinson's disease, and is actually very, very common. So it's characterized by sudden and brief episodes of inability to take that next step. Usually it occurs when you start walking, so the initiation of walking, that first step, turning, narrow spaces, and under stressful conditions, or when you're trying to do more than one thing at a time, kind of that dual task, or we talk about dual task and set switching, and I'll explain those terms a little more later. So why is it so debilitating? Freezing can be unpredictable. It can be associated with your off times when your medications are wearing off. It can be associated in more stressful or conditions where your anxiety is higher. But it can be a little bit unpredictable, which makes it a major risk for falls and hospitalizations. And especially turning, I believe, is one of the predominant causes of falling with freezing. And it affects everybody's independence and your quality of life, because if you can't confidently get out and move, then you tend to not go places. And we all know, and I know Steph and Lisa talk to you about this all the time, how important that activity is, the social connection is. You've heard this from them a lot. And that's why your group classes are so important, because you're connected, you're being challenged cognitively, you've got that support of that group that you're working out with. So when you experience a lot of freezing and you aren't able to get out and go about your normal activities, then it really affects your quality of life. So we can describe it kind of two different ways. We can describe it based on the type of leg movement during the freezing episodes. So kind of picture, and I'm not going to demonstrate today because I actually dropped something on my big toe and I can't hardly stand up and walk right now. So I'm just you can just picture in your mind, if you're standing there and you're going to take that next step, and instead of that step forward, you get the alternating trembling leg movement. So they're just kind of shaking in place, right? And you just can't generate that force to take that step. Kind of another freezing is that when the steps get smaller and smaller and smaller, to where you're shuffling and your upper body gets ahead of your feet and you tend to fall. And then when there's no movement of the legs, or it's called akinesia, absence of movement. I think that's a lot of what happens with those turns, right? You go to turn and your body's going and your feet have not moved. And so that's another big cause of falls. You can also talk about freezing of gait based on some of the underlying symptoms and triggers. So is it motor impairment that has to do with balance, with your width of your gait, a lot of difficulty with those kinds of actual strength and range of motion and mobility issues? Is it anxiety related, which is a very common trigger for freezing of gait? Or is it more related to attentional impairments? So Parkinson's includes not just the motor symptoms that we can see, but all those non-motor symptoms. So cognitive function, dual task, or set switching, which is our brain being able to switch from one task to another, or prioritize the most important thing. So sometimes our brains don't prioritize safety, or they prioritize speed, or they prioritize movement over safety. Sustained attention, being able to continue to pay attention and focus long enough to stay safe. So we can talk about it in a couple of different ways, but it's really hard to say what causes it. The cause is unclear and very complex, because it's all of those things factor into freezing. Now, you all know what Parkinson's disease is. I'm assuming you've fairly familiar with the basal ganglia in the brain, which are affected by not having enough dopamine to make that system work. And dopamine is a neurotransmitter chemical in your brain that's naturally occurring that helps regulate your body's movement. By the time you have symptoms, whether it's a tremor or you've lack of arm swing or that, kind of masked face or some of those, gait or balance problems, you've usually had Parkinson's for a while, and you've had 50 to 60% of those dopamine producing neurons are already dead. They've already died off. So you're lacking enough dopamine to make those systems work very well. And it usually precedes a diagnosis by 5, 6, 10 years. In fact, they're doing a lot of research right now, which is really fascinating. And I love Lori Mischley's research a lot. You heard her talk a couple months ago about trying to, look at, if we can even get those prodromal symptoms and figure out how to diagnose people sooner or know who's at a risk, then we can start changing lifestyle and exercise and things earlier to affect the course of the disease. So as of right now, usually by the time people are diagnosed, they've had Parkinson's for a while and they don't have a lot of dopamine in their brain naturally occurring. It isn't just dopamine doesn't just affect your movement. It also works on coordination and sequencing and timing. It's a big reward base. So it makes you feel good when you have more dopamine in your system. And sometimes there can have this dopamine dysregulation thing where people end up with some compulsive problems because they're of the dopamine systems all out of whack. But it works as a signaling molecule. It helps your brain communicate. And there are different pathways that rely on that dopamine to help them work well. So it's very important in that Parkinson's disease, we have to think about the fact that we have multiple parallel basal ganglia pathways. So it isn't just the basal ganglia only helps with movement. It helps with your motor, habitual and goal-directed movements. So habitual are all those things that you don't have to think about when you just get up and go and you don't have to think twice about it. Goal-directed movements are when you're actually planning and thinking, I'm going, really looking at something and taking the time to think and plan. So we have both habitual or automatic, which is what everyone knows. Usually those automatic pathways go down first and become affected first in Parkinson's, but we still have that other goal-directed pathway where we can use that to help us continue to move and move well. So executive function and attention, those circuits are all affected by dopamine and the amount of dopamine being circulated in that system. And then motivation and reward. So that's the limbic circuits. And so that's a really important thing to think about. We have lots of ways to tap into existing pathways or undamaged pathways, even when our habitual pathways are very severely compromised. And we want to use all of those pathways to help our quality of our movement and our safety and our function be good, or optimize it would be a way to say it. So we can look at treating freezing by multiple different things. Medications it's important that your medications are optimized. A lot of times that freezing happens during those off times or when you're coming, when the medication is not as effective. So it's kind of that bell curve on most Parkinson's medications, takes a little while to get up into your brain, get effective, and then it kind of wears off before you take your next dose. So a lot of times freezing is off freezing when you're in an off stage. So talking to your doctor about making sure your medications are optimized. Are you taking the right amount? Is your timing right? Are you eating right? Are you doing as much as you can to optimize those medications? Of course, I'm a therapist, and I think therapy is essential for all people with Parkinson's. And I think this having, you having access to Lisa gives you that therapy perspective, but actually having some one-on-one physical therapy is the goal, and having that therapy, getting to know that therapist in the get-go from the beginning, from when you're diagnosed, so that they can help you problem solve over time and help you stay active and continue to exercise and function at your highest level. So I'm really a big fan of therapy, and that one-on-one therapy, helping you problem solve. And when we talk about using some of these things like internal cueing strategies, external cueing devices, cognitive training, all of those things a therapist can really help you with to optimize your ability to keep moving and minimize your freezing. So sometimes we can't prevent a freeze, but we can teach you how to get out of a freeze. We can also work on preventing that freezing from happening at all. Now, DBS, which is deep brain stimulation, is known to be somewhat effective as in preventing freezing of gait along the same line as medications. So medications help if they're, when you're optimized on your medication. Deep brain stimulation seems to mimic the act of the medication. So if you do well on medication, then a deep brain stimulator is a more continuous stimulation. It's on, on whatever they've got that set at for your settings on your deep brain stimulator. And they have the ability to play around with those sometimes and have different settings to help more with your walking or more with your speech, or depending on what your problems are. But deep brain stimulation is neurosurgery, and it is appropriate for the right candidates. And there are a lot of people who it is not appropriate for. So we're going to talk a lot about things that you can do to help manage your freezing. So number one, talk to your doctor. Talk to them about all your different medications. They do sometimes use some stimulants like Ritalin. There are different medications that seem to help most likely with that focused attention, or the ability to get that executive function working and pay attention and be focused. Amantadine is an agonist type medication that helps, and the MOBA inhibitors help. So all of those medications, as well as any of your dopamine replacement medications. So that's carbidopa levodopa, which is also Cinemet, Rytari. There's extended release. There's all kinds of different versions of carbidopa levodopa out there now. So talk to your doctor about that. Talk to your therapist and find a therapist that can help you with some of these issues. So when we look at therapy for freezing, the very first thing I'm going to do as a therapist is I'm going to assess. I'm going to watch you move. I'm going to look at how you problem solve, how you get in and out of different positions, and what kinds of movement patterns you have. Look at your stiffness and your range of motion and your sequencing and timing and coordination, and how slow you are and how stiff you are. And I'm going to look at what can I do to address the underlying problems. So I'm going to look at improving mobility. That's what a lot you do when you do your exercise classes. You're doing a lot of that with Lisa and stuff. You're working on getting your mobility, so your range of motion within your trunk, your axial mobility, getting your posture better, getting your weight shifting better, working on that wider base of support, getting a lot of those things working more smoothly with better timing, better sequencing. So that's where a lot of those exercise classes, where they're challenging you all the time and you're moving and you're working on patterns of sequencing and balance, that's really going to help you. Okay, so as a therapist, I always want to try to help you become the best person you can be from a mobility standpoint. But sometimes we have to compensate. Sometimes we have to use some tools to offset the problem. So I might teach some compensatory strategies. So some of those strategies have to do with, and we'll talk a little bit more about what a freeze recovery strategy is, or how to get out of a freeze if you get into a freeze, or how to prevent a freeze from happening. And then sometimes we have to make adaptations. So we have to live life despite the problem. And those are things like changing our environment. So if we know that small spaces, crowded spaces, doorways, thresholds, all of, throw rugs where there's difference in, visual changes in our environment. We can modify and do a lot of changing to simplify that and to take away a lot of those triggers that might cause a freeze to start up. So it's one of the benefits for me being able to be a home health therapist is that I get to go into people's homes and actually help modify those environments and change that situation so that it is a more ideal for that person's problems, specific problems. And I might add targets and cueing and different devices and things to adapt to some of these problems as well. Okay, so we talked a little bit about posture, motor problems. So bradykinesia is this slower movements. It's actually a force modulation problem. So when you have bradykinesia, your brain is, when you go to move fast, your fast movements are small, and when you move slow, everything's just it's all discombobulated. So working on scaling your movements to the right size. So it isn't all about just big movements. It's about modulating, putting the right amount of effort in for that specific task. Stiffness and rigidity is huge in Parkinson's. So trunk rigidity, especially. A lot of people with Parkinson's have back pain and shoulder problems, and a lot of that is related to their Parkinson's stiffness and rigidity. So that's where a lot of exercise comes in. A lot of that community-based exercise and the things you do with Lisa and staff are important. Now, in the old days, so I've been a therapist for almost 40 years now, and in the old days with people with Parkinson's, therapy, exercise and therapy weren't considered to be very beneficial. So we wouldn't see people with Parkinson's until basically I'd see a Parkinson's patient when they were so stiff they couldn't hardly move, or when they're in such a kyphotic stiff posture they can't even lay flat in bed or get out of bed. So we used to just teach compensation. So if you're a fall risk, then use a walker. If you have stiffness, then you just add more pillows and support if you can't lay flat. But what we found is that people with Parkinson's have, and the reason I like working with people with Parkinson's is there's so much potential there. A lot of it is we need to teach you how to access all the different tools you have and all the different pathways within your brain. So we actually, instead of saying don't ever walk and carry something, or don't ever walk and look around, we start working on dual task, doing more than one thing at a time. Working in simple things that you do in your exercise class are dual tasks. So when you're actually on Zoom and you're having to follow and listen and change directions or change hands or do the same movement in a different backwards pattern versus forwards pattern, all those different things are all cognitive dual tasking. And so you're getting a lot of that when you work with them on dual task and set switching and focus and attention. So that focused attention is where I see a lot of falls, because of that lack of ability to sustain attention and keep paying attention over time. So coordination, timing, and sequencing are big parts of what I work on a lot. A lot of people think that their legs are weak because they have trouble getting up, when actually, if you muscle test them, their muscles are strong, but their brain is not telling them to move in the right sequences. So they don't lean forward enough to get their quads to activate, so they get stuck. They just feel like they can't get up and down. So it's another reason it's really a very positive thing to work with people with Parkinson's, because you can learn how to move in more normal, coordinated patterns to get up and down out of a chair, to roll in bed, to get up and down off the floor. And then the more you practice, the more you can do that. Might also work on anxiety, so breathing, relaxation, yoga type things, adding a focus on breath and breathing can really help. And then keeping you fit and staying active and getting you to continue to exercise is typically one of the hardest parts that I see with the later stage Parkinson's. But once you get involved in and you have a group that's your support group and you're exercising together, that camaraderie really, really helps. So that's a lot of what one-on-one therapy can do to help you deal with any kind of freezing problem that you might have. Now, if I'm going to modify the environment, I'm going to do some compensatory strategies. I'm going to say, okay, we got to take up throw rugs. We need to open up spaces. We might move furniture around a little bit so you've got a straighter, clearer pathway. I might add targets or cues. So maybe it helps to look up instead of looking at the floor, because a lot of times when you look down, it increases that flex posture, puts more weight over the balls of your feet, and makes it harder to take that step. It kind of is feeds into that freeze. So maybe we add some visual targets or cues. I might have you practice with different things. Grab bars, I might add, to get you to lean forward and reach and either use that grab bar or touch a dot on the wall. It doesn't have to be a grab bar, just to get that timing and sequencing better. I can add tools. So I can use an external cueing device, and there's visual, auditory, and somatosensory types of external cueing devices. So you've probably seen some of the external visual cueing devices. That would be things like the laser line that comes with either the U step or the next stride, or I keep getting on my Facebook feed these shoes. I can't think what they're called, but they have little laser lights that go on the front of your shoes. That idea of having that target to step 2 is a external cueing device. So that's tapping into not the habitual or automatic, but into the goal-directed side of those basal ganglia pathways. So I might add an external cue to get your brain to use the goal-directed. So the goal is to step over the line or on the line, and that may get you out of a freeze or prevent a freeze. There's metronomes and music. All of those things can help you continue to move and keep moving at a nice, even, steady pace. Music can work really, really well, but the research shows it has to be music that you like and that you enjoy. But you can use music that has a certain number of beats per minute or a certain soundtrack that you really like. So auditory works really well. They're doing some research with like vibratory, somatosensory kind of type of cues under the feet and the insoles, kind of those types of things to help you continue or move to take that step. I know in the old days they used to see this as a strategy. It's like, okay, if somebody's having trouble taking that, getting that next step, you just kind of put your foot out in front of them, and they have to pick their foot up and to go over that step, right? So I've provided an external visual cue. One woman developed this whole series of holographic stairs that was a decal for the floor that she put in her dad's house. So when he thought he was, stepping upstairs, he would take a bigger step to step up that step. So again, that's a external cueing device. That's more of a visual cue. I often do use internal cueing devices and strategies. So some of that is things like the ability to recognize when you're starting to freeze or your steps are getting smaller, you're starting to get your weight too far out of your feet. There's the strategies of stop and stand up. I think I have it here, the 5S strategy. So stop, stand up tall, sigh, which just gets you to relax a little bit, take that deep breath, shift your weight side to side, because weight shift is a huge part of problem with freezing, and then start over with that big step, right? That's kind of that 5S strategy. The weight shift, if you think about it, if you're standing with your feet kind of close together and you want to pick up one leg, you can't pick up a leg if you've got all your weight on it. You have to shift off that leg in order to move it. And if your feet are too close together, you're really unstable if you shift very far. So that's why that's getting those feet apart and shifting side to side really helps. Another strategy I I use a lot, that's more of it as an internal strategy, is called a step prediction strategy. So it is the purpose of it is if you're walking, you look at an object in the distance and you plan that I'm going to get from here to the next doorway, and you predict how many steps you think it will take you to get there. So if I'm walking down the hall in my house and I plan to get there in 6 steps, most often people get there within 5 to 7 steps. So that step prediction strategy does a lot of different things. It gets people to look up, which improves their posture. It gets them to be focused and intentional with their movements. So it gets them to achieve, they're really using that goal directed pathway, not the habitual pathway. And if it can work really, really well. If I just count somebody's steps, that isn't the same thing as having them predict or get to a certain point within a certain number of steps. So it's a different strategy than just counting your steps. A lot of times if somebody's just counting their steps, they still continue to get smaller and faster and smaller and faster and become more shuffly. And you're just counting faster as you go. But that whole purpose of that step prediction is to get up tall and take that big step. So it works really well. So those are internal kind of cueing strategies or things that you can use. And if you can't remember them, then your care partner can help you, or remember those, or maybe have some little signal or cue that helps you remember those things. So adding some of those things can work. We talked about, the next stride. I know I've helped them with that a little bit in making that device portable and cueing. And the idea with that too, I use an internal strategy, even with that laser line or that metronome, and that you don't always have to look at the line, but you can always internalize that and say, okay, I'm visualizing, I know where that line is. Maybe I look down and I think about it, but then I look up and I visualize myself stepping over onto it. So I don't have to rely on it all the time. The nice thing about it is it's easy to turn it off and then turn it on when you need it. You don't have to have it on all the time. And that variability actually helps you internalize and learn how to manage your freezing better and don't become so reliant on that visual cue. But if you need the visual cue, you need the visual cue. You need that external device. So adaptation or things that you can do. So adding a cane or a walker sometimes helps and sometimes it makes it worse, right? So if I have cognitive issues with sequencing and doing 2 things at once, and I'm trying to use a cane or hiking poles, I may find that when I'm attending to moving the cane or moving the hiking poles, it just makes everything else worse because I can't do multiple things at one time. So some, hiking poles I like over a cane. They can be 2 poles at once. They can be, the sequence doesn't matter as long as you can be safe with them. A walker oftentimes is less, doesn't require as much thinking as a cane does. And a lot of times people are better off without an assisted device, but maybe if they're going to get out and walk for exercise, they walk with someone and they walk arm in arm or hand in hand for that support and that ability to walk better and more freely without the conscious having to manage that device. Teaching care partners some of those cueing strategies, having something that, you guys have a signal between each other as to, stand up tall, take a deep breath. I'm always, my patients, I'm always giving them that cue to take that deep breath. So sometimes they laugh at me because I do a lot of this around them because I want them to stop, stand up, refocus, and start over. Sometimes you have to just have more supervision. You have to have somebody help you, remind you more often because you're having trouble with that sustained attention or your memory or your recall, and you're getting stuck more often. And sometimes in the late stages in Parkinson's, we just modify our mobility expectations. It's, that if you're out in a crowd and there's a lot of people around and your freezing is going to be severe in that situation or unpredictable in that situation, then just take that walking out of the picture and use a wheelchair. It's okay. If it's more important to get out and enjoy your life and see people and do things when we get through COVID than to stay home and isolate yourself because you're so afraid of having that freezing episode happen when you're out in public. So we all know it's, gosh, been a long time now we've been dealing with COVID and the isolation and not being together. And there's lots and lots of research and that's not very healthy for any of us, and especially people with Parkinson's. So knowing that, we want you to live your life and modify things as you need to so that you can continue to move and be as mobile as possible. So, gosh, if I'm thinking about therapy goals, things that I'm going to work on with my patients, I want you to be able to use compensatory strategies or cueing devices or environmental modifications to manage your freezing of gait episodes, either in your house or out in the community. I'm going to do lots of things to instruct and educate you and your care partners in wide-based gait, weight shift, upright posture. I'm going to teach you how to use cueing devices, simple targets. Maybe it's a line over the threshold so that you have a piece of painter's tape that you have to step over versus having your brain trying to figure out where exactly that threshold is. Sometimes that's, a hand goes here. Sometimes I put a simple little reminder and it's taped to the wall to remember to do that, stand up, take a deep breath before you take that step in the bathroom, if that's where you tend to have those smaller spaces, right? Anti-freeze and freeze prevention strategies, turning, practicing that turning. And you probably do quite a bit of practice with that sort of stuff in your exercise class, but there are lots of different turning strategies that you need to practice and work with. But we can do wide-based turn strategies, kind of a wide-based waddle. There's the idea of a kickstand or turn signal turn, making sure you're getting that foot to go first, not have your feet be frozen and your body go and you fall. There's pivot turn strategies. There's lots of different ways to work on turning strategies. And then breathing and relaxation techniques, talking about recognizing and being attuned to when you either know that situation is typically something that triggers a freeze, or you feel yourself starting to get into that shuffling gait pattern, how to stop, stand up, take that deep breath, and start over again, right? So as a therapist, I'm working right now to really work on training other therapists to have more education about Parkinson's specific exercise and Parkinson's specific mobility, what it means to be a Parkinson's specialist is, you can look and find PTs and OTs who have some kind of education or training. The APTA has a Find the PT website, and people are on there and can list their experience and what they've done. Right now, there's two main programs. So LSVT Big and LS is for PTs and OTs, and LSVT Loud is the speech therapy program that is a Parkinson specific program that's a protocol driven program. There's Power Moves and Therapist Instructor, which is a good, more flexible, basically framework for working with people with Parkinson's. There's Speak Out, which is a speech program that's similar to LSVT Loud, but again, works a little more with cognition, which if you're a freezer, you want to see a speech therapist and help you figure out how to work on some of that set switching and dual task and sustained attention. All of those things a speech therapist can help you with. Other PTs maybe do some training through Delay the Disease, or there's the Parkinson's Foundation has PTOTs. They don't have speech, PTOT and nurse courses for people to take to become more specialized in Parkinson's disease. So you're going to look for those kinds of people to get that help that you would need. And then, those people like Steph and Lisa who are providing Parkinson's specific exercise out in the community is key. So you need to have kind of a relationship between, you're a therapist and your exercise professionals and your physician, and everybody needs to be working together as a team because it takes a village really to deal with this chronic disease, right? So you have a long-term disease that you have to manage over time. And in order to live your best life and stay healthy, you've got to have help from a lot of different people. So finding that care team is really, really important. So that is, in a very fast nutshell, a lot of information about Parkinson's disease and freezing of gait. So let me get out of my slideshow and stop sharing my screen so I can see you all again.
Awesome. Thank you, Maria. That was amazing. We have one question, and I'm sure others have questions. Well, the first question that we have is, when in a PD journey does it occur? I'm assuming they mean fog. And does it ever go away? Does everybody get it?
So no, not everybody gets it. People that have more the stiffness, the rigidity, the postural instability, gait dominant type of Parkinson's tend to have more problems with freezing of gait. Again, Parkinson's, it could be up to 80% of people, but that means there's another 20% who maybe never have freezing of gait. If you have more the tremor dominant Parkinson's, or you have young onset Parkinson's, those are all kind of different phenotypes, or they have a different course of the disease. It tends to progress at a little different pace or in a little different manner. So if you would have that PIGD, postural instability gait dominant type of problems, then you're more apt to have it. I don't know that it ever really goes away, but you can manage that disease by understanding what situations it occurs in. There's a lot of that anxiety. You can have Parkinson's freezing that is related to anxiety. So if you can manage your anxiety through maybe medications, maybe some therapy and counseling, maybe using breathing and relaxation and taking yoga or Tai Chi and learning how to control a lot of that, you can manage it so that you don't have those freezing episodes. But it depends on what the cause of your freezing is. And is it related to that anxiety? Is it related to your narrow base of support and your flex posture? So you can make all those underlying causes better and have less, frequency of freezing of gait.
That's really helpful. Yeah, that's really helpful. A lot of people ask us about that, and I think that was a really great answer. So thank you for clearing that up.
And I especially love that we can do something about it.
Yeah, that's
addressing
awesome.
all of those, postural or the stiffness or the weight shifting. We can address those things, which we do in class anyway. So,
but you guys do in class all the time, and that's why it's so beneficial. I mean, all exercise is good exercise, but Parkinson's specific exercise is going to target those problem areas more. Parkinson's specific exercise is going to work on that upright posture, that axial mobility, that weight shift, and then challenging you cognitively. That whole idea of being able to dual task or set switch or be able to think on your feet is super important in freezing of gait. That's why it's Parkinson's specific exercise is so important. Cardio exercise is great, but it doesn't tend to work on, works on getting that blood flow to your brain, and it seems to help a lot, but it isn't really cognitively challenging unless you do Peloton, maybe an interval training. Then it's a little more cognitively challenging, right? So that's why the benefit of having a Parkinson's specific exercise class and seeing a Parkinson's specific therapist is really, really important.
And we touched base about that in class today as well. So I'm really glad that it's really tying into what we were talking about today and how important that Parkinson specific exercise is. So thank you. Okay, the next question, does that mean one would not have both fog and tremors?
No, it's just that it's more common in the postural instability group, but tremors, 30% of people with Parkinson's don't have tremors, but 70 to 80% do. Eventually, most people do end up having tremors. The tremor, when you're talking about those phenotypes, it's like the tremor dominant tends to be, it's just a different progression where tremor is your primary major symptom. And it's a certain phenotype. It's different than if you have a lot of stiffness and rigidity and bradykinesia and all those things. But it doesn't mean that you're not going to have a freezing problem. It may be just a different trigger, right? Maybe it's because of look at those underlying either physical causes or some of the social situations or emotional situations. They're all just going to be a little bit different, but it's less. I think it happens sooner in the stiffness and rigidity, and tends to happen later with the tremor dominant, but it doesn't mean you won't have it, unfortunately.
Someone just made a comment saying my Tai Chi did not have the dual task. And that's interesting.
Well, so Tai Chi, there is a certain element of set switching and dual task in that you're coordinating your breathing, you're following along with the instructor, you're working on a pattern, right? So you're having to remember that pattern, you're having to stay focused. So it's Tai Chi is great for weight shifting, obviously. It's great for focused attention. It's great for breathing and relaxation and posture. So Tai Chi can help with a lot of those things, but it isn't the same as it's more beneficial in those areas. It's not a lot of set switching where you're having to do a lot of move this direction, then move this direction, or do a task where I'm, I could say, I want you to stand up and touch follow a sequence, touch all the numbers in sequence, 1, 2, 3. So now I'm doing something that's a weight shifting task, that's a cognitive task. But anytime all of your classes are dual tasks because all of your participants are following you on Zoom, having to pay attention, listen, watch, and adjust and do different things. So there's an element of dual task or set switching in all of your classes that you're doing in a group format like that. That's one of the reasons group classes are so good, because it is challenging you in a lot of different ways.
Great.
It looks like Jim has his hand up. You have a question, Jim?
You have to unmute.
Yeah, I got it. So yeah, you indicated in the introduction that you're going to talk about the freezing of gait primarily, but there's other forms.
I've got somebody trying to call me. Hold on, and I can't get them to.
Sure.
I can't silence. Oh, it's my other phone. Sorry. I got my phone hooked up to my things, and they keep trying to call me.
You're important today.
I know, everybody calls at the wrong time. I've been here at work all day in this conference room all by myself. And now when I'm talking to all of you, the phone rings.
So are you ready?
I'm ready. Yes, go ahead.
So you indicated in the introduction that you're going to talk about primarily the freezing of gait, but there's other forms of freezing. And I thought you were indicating one of them might be mental, but are there what other forms of freezing did you not talk about necessarily? And is there a connection to freezing of gait and other forms of types of freezing?
I don't, that's a good question as far as the incidence of other things, but so just like you can have slowness and coordination of movement problems, you can have slowness in your thinking. It's called bradyphrenia. Your swallow is slow. Your voice is, soft and it's not the right force modulation. So it doesn't just affect your limb movements or your trunk movements, it affects your voice, your thinking. So you can have actual freezing problems, say with trying to feed yourself, getting that, arm, any coordinated kind of movement, or within your thinking processes as well. I don't know that it's been studied that much, so I don't have a lot of input on that, other than I know the whole idea of relaxation, deep breaths, intentional movement. So planning, using lots of external cueing and targets works. So if you think of, you got a pathway in your brain that's a basal ganglia pathway on this side, and it's all the automatic stuff that you don't even have to think about. You just get up and go. Then you've got this pathway over here that's goal directed, right? So it's very intentional and specific. And if this side is damaged, then I want to use this side. So if I can tap into that goal directed pathway and use it to accomplish my functional task, then that's what I want to do. So that's all those kinds of strategies, or providing a target, increasing, like I could provide, sometimes providing resistance makes you move bigger, right? So there's lots of things I could do to make maybe that hand to mouth thing easier. Maybe I'll do a lot of work with actual, reaching to targets, maybe a number, anything that helps you, be more intentional and more specific would maybe work. But that's why you would need to see a PT or a speech therapist or an OT that could help you figure out what would work for you, because it's so individual. It just depends on the cause of the freezing and what your limitations are and what works for you, because you don't know till you try it. That makes sense?
Yeah, thank you.
You're welcome.
May I ask a question? This is Joan. I'm just curious whether this is a great presentation, by the way. Thank you so much. It's fabulous.
You're welcome.
Is there any benefit to doing exercise workout in my off time on my meds? It's much more frustrating and difficult, obviously, but from what you're talking about with getting a different pathway to work, I wonder if my certain pathways are not functioning, if by forcing myself to do these movements when I'm off, if I'm accomplishing anything or just frustrating myself.
I think it's fine to exercise. If you have, ideally it'd be great if you didn't have those off times, but you still have to function in those off times, right? So those off times might mean that you would need to add more external cueing or strategies. So to make that work. So, that's a lot of that. Is if I'm going to say reach to here, that's, people, this is what your brain tells you to do. But if I put a target up there, or I asked you to reach out and hit something, now I've channeled that, not the habitual pathway, which this is the damaged habitual pathway. It says reach, and it says back. But if I give you a target and you get there, or if I say I want you to, I want you to move bigger or faster because your movements are really slow, then I may give you something to hit or slap or a boom whack, or something to make that movement bigger, or maybe throw a scarf, right? If I want a bigger, faster movement, I can add things. So if I was going to exercise in those off times, rather than let it be so frustrating, I would try to add more external targets and cues, or add support. So if I'm trying to reach and this is my posture and this is as far as I go, but if I'm here and I have a target and I feel bigger, I can more confident and I can move bigger, then I want to practice with that. So I think if I was exercising in a time when I didn't have as much dopamine in my system, I would add more support, more targets, more cueing, and I would work with it that way, rather than just keep trying to do the same exercise and get frustrated. You always want to set yourself up to be as successful as possible, and you want to have fun. That's why Lisa and Steph are so good, because if it's not fun, that's the reward part of those basal ganglia systems. You have to enjoy it, or you're not going to keep doing it.
Right. That's a great answer. Thank you so much. That's extremely helpful.
You're
Thank
welcome.
you.
And you have to challenge yourself. You know what I did on Saturday? I took a flying trapeze lesson. And it was so much fun.
Awesome.
It was so much fun. Talk about sore though. I am so sore, but it was exhilarating. It was fun and I want to do it again, right? So finding, not everybody wants to do flying trapeze, but I loved it and I would go do it again in a heartbeat. So finding ways to be successful. And that was this, they did a great job making everybody in this lesson be successful. We actually got to swing and hang upside down by our legs. And the third time he caught, the catcher caught everybody except for one person, I think. So everybody was successful. So that's important to make, you know, modify things so that you're still exercising at a good level, but give yourself more external cues and targets so that you are successful and moving well. Quality over quantity.
That was a really great question, Joan and Maria. That was amazing. I hope everyone listened to that whole answer right there, and that you're not swirling out. You know, I know we're close to the end, but yeah.
I do have a question though. I have a question for, let's say you don't even know if you have freezing, but one of the things you've noticed that you're kind of on your toes every now and then, and you're not sure why it's happening. And so I'd like to ask you, you know, what is the one thing that you would want this person to really pay attention to and to maybe do as a treatment or an exercise as a technique, perhaps?
So typically that festination, that where you get your weight, a lot of that, if you were to be on your toes and think about that, you're probably flexed forward, your head is over your toes, your weight is forward, your feet are probably too close together. So, and that's things that maybe you aren't seeing unless somebody helps you see that, or you see a picture or a video of yourself so you can see when that is what's leading into that. And a lot of that has to do with that postural problem that's part of Parkinson's. So that you don't have good balance in that flex posture. And when your movements are getting smaller and smaller and faster, you end up on those tippy toes and you're at a risk for going over. So you want to be able to recognize before you get to that point, that upright posture, looking ahead, not looking straight down at your toes, looking down and making sure your pathway is clear, correct, but then planning ahead, looking ahead, being more intentional, working on those bigger, slower, more controlled steps over a longer period of time is really, and then posture. I think everybody with Parkinson's needs to spend time working on that extension, spending time stretched all the way out flat. I love, I get even my home health patients up and down off the floor all the time because it's so important to be able to get flat on a good firm surface and stretch everything out and work on that posture. So working on those components and then practicing more intentional movements. You might have to have somebody video you or something so you can see when it's happening, I think, because you can't, that's a basal ganglia system also is part of your proprioceptive input. So you think you're talking perfectly fine or you're moving fine until you actually maybe see it, or you can feel the difference because your brain is not giving you good information. That's your brain on Parkinson's. So I do use videos and pictures a lot to help people feel it or see it.
Awesome.
Does that make sense, Lisa?
Yeah, absolutely. And just how empowered people can feel about knowing that they have techniques that they can use, multiple techniques to prevent things from really developing into full-on freezing and fascination.
Question.
Yeah. Right. So instead of the freeze controlling you, it's you being able to use lots of different strategies to take control of that. Yep. Empowerment. I like that word a lot. That's a lot of what we do as exercise professionals and therapists is empower you to get better and stay better and manage this disease over a long course of time, right?
Yeah. Does anyone else have a question?
I didn't hear that.
Oh, I said, does anyone else have a question?
Oh.
Yeah,
Go ahead, Renee.
She just muted herself again.
Oh, okay. If you can get unmuted again, Renee, then we can.
Okay.
Okay.
I noticed in one of the set of flashboards that were behind you during the presentation that it mentioned the death of cells. The cells get taken. Which cells are they, and why don't they? They can be replaced, or
So they're neurons that produce dopamine, and so in Parkinson's, it's those, and then oh gosh, I'm having word finding problems. Lisa, help me out here. What's the protein? Alpha-synuclein, and then they misfold and they clump up, and so there's if we wanted to talk about the whole causes of Parkinson's or what's causing that, there's a lot of information out there about they don't really know why the cells die. If they knew that, or if they could figure that out, then they could make a vaccine, or they could have a medication to slow the disease down. But they don't even have a good biomarker right now to know who has Parkinson's. And the only way they diagnose it is based on your symptoms. And so by the time you have enough symptoms showing, you've already had a lot of these neurons that are dopamine producing neurons die, and they clump up, and they there's a thought that they that you don't have a good garbage disposal mechanism, so they kind of just sit around in there and create these Lewy bodies that take up space and infect other cells, and they just die over time. But the good news is that exercise, diet, lifestyle, all of those things, and there's starting to be more and more research about exercise affecting the rate of how those cells die and how many of them clump up. So exercise is a good option for trying to slow that process down. It does seem to be research that shows it starts in the gut and travels up your vagus nerve and hits your midbrain or your brainstem, and then travels out to your cortex. So by the time it gets to where you have movement problems, it's already affected your sense of smell, your sleep problems, constipation. All of those are things that you start having trouble with a long time before you have motor symptoms, because you don't get the motor symptoms until you get to the cortex, and it progresses on up through. That's Brock's hypothesis, which is fairly well researched and seems to be the progression of why things happen that way, and why you tend to, if you think back, you had sleep problems, constipation, and loss of smell earlier than you had any tremor or motor symptoms. So I hope that answers your question, but
Great.
yeah, that's where a lot of the research is going. Michael J. Fox Foundation is the leading, researchers as far as that goes. They spend billions and millions of dollars on trying to find a way to stop the disease or cure it from actually getting up to the brain, right? If they could stop those cells from traveling up and getting into your brain, you would never have Parkinson's.
Great. Thank you so much, Maria. We really appreciate you being here today with us. And
you're welcome.
Yeah, we've had a great time. I think you answered all of our questions, and it was, beyond our expectations of what we were going to hear today.
Thank you.